and that applies both to the procurement contracts and the National Audit Office report that we saw the other day, and to appointments. I think, my honest view is the government's sort of been a little bit on the slow side on that, but it is a balance. It's totally legitimate in the early phases of a crisis to throw everything at it, and that's a judgment in the end that ministers make as the representatives of citizens. But really important now to make sure that the public have confidence in these processes, and that we root out any suggestion that there's impropriety or anything around those contracts.
Thank you very much indeed, and thank you for joining us this morning. Professor Sridhar, thank you for joining us from Edinburgh. Very important evidence, and we really appreciate you giving up the time. Now we have the Health Secretary here. Thank you very much indeed for joining us. We know how busy you are. And thank you too to your team at DHSC, who are also working incredibly hard, have been during the pandemic, and perhaps not often credited in the way that frontline NHS workers are. Joining us virtually also is Clara Swinson, who is the Director General of Global and Public Health at DHSC, and Dr. Jenny Harris, the Deputy Chief Medical Officer. Thank you too for joining us. Let me open, Secretary of State. We've had good news in the last few weeks, and yesterday the Prime Minister said that he hoped the vast majority of vulnerable people would have the vaccine by Easter. The virus, of course, won't be eradicated by Easter, but if that happens, if all those vulnerable people do get vaccinated by Easter, what will the social distancing look like after Easter?
Well, the answer is that it depends on the impact of the rollout of the vaccine on the transmission of the disease and on the number of people who have a serious morbidity or indeed die from coronavirus. So the same tools that we use and the same data that we use to judge what should happen to NPIs now, to the social distancing interventions, are essentially the same measures because they are the things that we're trying to protect against. We're trying to protect against cases of coronavirus, hospitalizations by coronavirus, and very much deaths from coronavirus. Now, the vaccine trials can successfully test in these large numbers of people in the trials, tens of thousands of people in each of the 3 that have so far reported positive efficacy. They can test for whether they protect an individual. There is some evidence in the AstraZeneca trial of protection from transmission, and that you not only protect yourself from coronavirus, but you reduce the likelihood of you transmitting. And we've been able to measure that because in the AstraZeneca trial, unlike the other 2 trials, there was regular testing of some of the participants all the way through. However, you can't know the true impact of that, and you can't calibrate it mathematically until you've seen the impact of having vaccinated a large number of people.
So I understand, I suppose just people watching at home really want to just get a sense, is it possible that we could be back to normal after Easter?
After Easter, we think that we will be getting back to normal. Now, there are some things that are no regrets, right? Washing your hands more and some parts of social distancing are no regrets things that we should, I think, will become commonplace. But those damaging social distancing interventions that have big downsides, whether economic downsides or social in terms of our well-being, I should hope that we can lift those after Easter if these 2 vaccines are approved by the regulator, which of course is an independent decision for the MHRA.
Thank you. Now, this joint inquiry that our 2 select committees are doing is about learning the lessons going forward from what we've experienced in the pandemic. And you've said many times that you are following the science. So let me start by asking, do you think you got the right scientific advice at the outset of the pandemic?
Well, this is slightly dangerous, Chair, but I'm going to question the premise of your first question on this subject, which is that I always try to say that I was guided by the science. And I noticed that in your evidence session, the scientists from Edinburgh said people followed the science. I always try to take the approach of being guided by the science.
You did say follow the science a number of times.
I may have said it colloquially, but the approach that I took and far more rigorously tried to describe was being guided by the science.
So was the scientific advice you got?
Yes, so let's get on to the
good?
substance, because the difference between following the science and guided by the science is that if you're following the science, it implies an automaticity, as opposed to the a ministerial judgment taking into account all of the effects based on the science, which is a truer reflection of what we did. The scientific advice, I think, was the best that was available, and it's tough because we started knowing nothing at all about this virus and nothing about its biological properties, nothing about its impact on humans, and then nothing about how it transmitted and the social side of it. And that information built over time.
So when you say it's the best that was available, but it wasn't the same as the scientific advice that was being given in South Korea, and SAGE didn't model test and trace as a response. They modelled testing at the early stages, but then the plan was very clear to stop testing once you had community transmission. In South Korea, they were modelling test and trace as a strategy right through the pandemic, right from the start. We didn't get there until the end of April. So I just want to come back. Did you get the best scientific advice right at the outset?
Well, what I'd say is that just a couple of things on that. The first thing is, on testing, it is wrong to say that the advice was to stop testing, and we didn't stop testing. We ramped testing up all the time. The problem was that the linear increase in the availability of testing was essentially was slower than the rise.
No, but the advice was to stop. Sorry, it's not that I want to be disrespectful. It's just there are so many questions to get through. The advice was very clear to stop community testing.
That's different.
Yeah, but that wasn't the advice that was being followed in Korea, Taiwan, Singapore, all those other countries.
But I think that this is aiming at the wrong target. The stopping community testing was a consequence of having to focus the tests on people in hospital, because there it has a direct impact on treatment. The big difference was that in South Korea and others, following their experience of SARS, they moved to NPIs much earlier. And if you think about
it wasn't just, sorry to interrupt, but it wasn't just NPIs, was it?
Because it was also contact.
Your clear advice was to stop community testing, which you announced.
I was told to stop community testing, and that we should also stop contact tracing.
But the World Health Organization advice was to carry on testing in the community right the way through. So this is why I'm really trying to get to the point of, did you get the right scientific advice at that point?
Well, I think that I got the best scientific advice that my scientific advisors could give me. Can we learn from it? That's what this whole process is all about. There's absolutely no doubt. Let me put it a different way. There's absolutely no doubt that we should, and we must learn from all of the international examples and from our own experience here about how we can best deal with a pandemic of any sort. Let me give you one example. Project Cygnus, which is now published. The problem with Project Cygnus wasn't the exercise itself, which you will no doubt remember well. The exercise was conducted well. All the lessons from it were noted and acted upon. We wouldn't have had the Coronavirus Act in draft had we not had Project Cygnus. It was a very important project. The problem was it started from the assumption that we were going to have a pandemic flu that was already rampant and widespread, because it was an exercise about what you do at the period at which lots of people are already dying. What it didn't ask was the prior question of what type of pandemic is most likely, what are the different characteristics of different pandemics like flu or coronavirus being two obvious examples, and can we act to stop getting to the position that at which Project Cygnus started off. And those are the prior questions that I think it's very important for everyone around the world to be asking as part of the lessons from this.
And that's why you've announced the setting up of the new British version of the Robert Koch Institute, which will hopefully do that horizon scanning. But can we just go back, because we clearly did learn lessons from around the world, and which is why you set up, when you came back from your own bout with the illness, the big testing program, the big test and trace program. Now, other countries used test and trace, and again I'm going back to East Asia, as a way of avoiding lockdowns. We actually ended up having to have a second lockdown. Is that because the test and trace program didn't meet your expectations, or were there other factors?
I put very little weight on the idea that the test and trace program ahead of the second lockdown was functioning to reduce transmission enormously. And by the time of the second lockdown, it had already broken the chains of transmission hundreds of thousands of times. The problem was, as happened in so many other European countries, that the overall number of cases was going up. So I don't lay that at the door of test and trace at all, because they'd expanded unbelievably fast in the circumstances. And as we will see, we're constantly improving the testing and tracing, but there was the biggest gap, the biggest fall off between the actual cases in the community and the total number of people who were contact traced was actually the gap between of people who were asymptomatic getting a test, and that was the biggest gap.
Why then, just a couple more from me, but why then did SAGE say in September that they thought test and trace was only having a marginal impact on controlling the transmission of the virus?
Because there were so many other things that were leading to upward pressure on the number of cases, and that's why we had to bring in stronger NPIs, stronger social distancing measures.
But it just seems strange when you've made this huge investment, £12 billion, massive increases in the amount of testing that's going on, that in September they would say that all that effort is only having a marginal impact.
Well, the thing is that you've got to look at what test and trace was doing in totality, as opposed to the very specific part that you mentioned. So in totality, we wouldn't have had the ability to test the people that we did unless we'd built the capacity. We wouldn't now be in a position of being able to roll out the very widespread community testing unless we'd taken the action that we did. But the central point is that the ability to use test and trace on its own cannot keep the virus under control, and I think that's true in all countries. So, for instance, in some of the Far Eastern countries where they see a number of cases, they will put in huge testing capability, and I think that mass testing does have that ability to do that in a way that testing of symptomatic people and then contact tracing finds it much harder to do, and nowhere uses test and trace without NPIs attached to it to control the virus. So to lay this at the door of test and trace, I think is wrong.
Final thing from me, Professor Sridhar talked about the importance of compliance when people are asked to isolate. And we've had fairly low compliance rates, around 20%, up to I think 54% was the latest number I saw. But she talked about New York City, where they've managed to get it up to 95% compliance with requests to isolate. What have you learned going forward about how we can boost compliance?
I think that the incentives to self-isolate are very important. I think the £500 payment is very important. I'm sceptical of some of the very high numbers when there are reports of very high proportions of people following those rules. I would want to look into the surveys or the incentives of people when answering those questions. Likewise, I'm highly sceptical of the very low numbers. For instance, the 20% figure you refer to is if people, the question is asked in a particular way about whether they fully, at all times in that isolation, abided by, stayed at home entirely. And there are, what matters is the radical reduction in the number of contacts. This isn't to say this isn't an incredibly important area where we have learned throughout the crisis and brought in stronger measures.
But who is responsible for getting the compliance rate on isolation up? Is that Test and Trace's job?
Well, test and trace, yes, but it's actually a cross-government effort because it requires enforcement, law enforcement, it requires Treasury for the payment and the financial support that people get. And so it's a cross-government effort and it's brought together at COVID-0.
Thank you. Carol Monaghan?
Thank you, Chair. Secretary of State, you have mentioned already scientific advice that you were receiving, and I don't think any of us want to be critical of those who were receiving the advice, but Professor Schreeder's already talked about the composition of SAGE and the high proportion of modelers as part of that. Have you made any attempt to widen the diversity of scientific advice that you're taking?
Well, I mean, absolutely. And I think that I listened to some of those comments. I thought it was a bit strange to say that SAGE doesn't have any public health expertise when it's chaired by one of the world's finest epidemiologists in Chris Whitty. Maybe if I asked Jenny Harries to come in on this as well, I thought that was that description. The part that I heard at the end of the session was not an accurate description of SAGE. Nevertheless, on your direct question, absolutely we listen to a broad range of advice. The formal way in which the SAGE advice is brought to ministers quite properly is through the CSA and the CMO, and we listen very carefully to them. But I also listen to all sorts of voices and scientific arguments, and I'll go and read some of the material direct. But you do also need a process through which.
Could I stop you there and just ask you? I mean, one of the areas that we were told very early in the pandemic that there was a kind of deficit of was engineers, manufacturing engineers, for example, who would be contributing to things like, for example, screens, machines for hospitals, even test kits. So are these kind of individuals now part of the advice that's been given, that's offering advice to government?
Well, I don't think having engineers and the operational skills and capabilities on SAGE would be right at all. That's not the job of SAGE. It's a scientific advisory committee. Of course, we use all those skills that you mentioned enormously in the assessment of what's the right policy and the rollout of it. I suppose this is, it comes down to.
Sorry to interrupt you again. If we're talking about, we've just heard from the chair talking about test and trace, and we've heard about lack of capability. And one of the reasons for lack of capability was limited numbers of test kits. So it's these very people that would actually be able to advise on how we can best increase capacity in that area. So I'm finding it strange that you're saying that they would not form part of the advice early on.
No, of course they form part of the advice. It's just nothing to do with SAGE.
Okay, I'll move on then. In early March, the UK was rejecting the idea of lockdown. We could see lockdowns happening in other countries worldwide and across Europe, and we know that, for example, Germany had a very robust response early on. But we kept hearing about reducing the peak and flattening the curve. A director of the Wellcome Trust, Sir Jeremy Farrar, has said that we were too slow to lock down, and as a result the epidemic took off and we weren't able to control it. Should we have put our lockdown measures in place earlier in the pandemic?
Well, this was a point at which we did directly follow the science as we were guided by it, and took that scientific advice. But
these were the scientific advice was coming from modelers. So my previous question was asking about the diversity. So I'm asking you now, in hindsight, should we have locked down earlier, knowing what was happening across the world and in other parts of Europe?
Well, there's so many ways to answer this question. The first thing is, I'm not sure that putting engineers onto stage would have made any difference to the advice at that juncture. And I think that's something of a red herring. We get advice on engineering requirements for any policy quite separately. There will be, of course, rightly, a debate about this question that you ask about what the advice should have been at the time. What I'd say in defence of the advice that we were given, which we followed, is that is that we put our lockdown measures in earlier within the pandemic curve than other comparable countries in Europe. And what's more, the 4 nations of the United Kingdom moved at the same time, despite, and they were essentially basing the decisions on advice of the 4 CMOs and the scientific advice that came to them.
I'm slightly confused, because 5 minutes ago you told the chair that you didn't follow scientific advice, you were guided by it, and now you're saying that you did follow scientific advice. Which is it?
I was very precise in what I said. In this instance and in the period that you're talking about, absolutely, we took and listened to and followed the scientific advice that was given, and based our decisions on that. What my point about saying that the better phrase is to be guided by the science is that there are times when that wasn't the case. You know, there's many examples when I can remember the scientific advice being different. For instance, right at the start of the pandemic, when we were bringing people back from Wuhan before the virus had escaped before we knew that the virus had escaped from China, the advice was not to quarantine those people on return, and I overruled it and decided that those people needed to quarantine. So that's an example of how of why ministers are there to take into account the scientific advice and then make a decision. In the case that you were mentioning of the March lockdown decisions, we took that scientific advice and we followed it precisely.
Thank you.
Okay, and finally,
last one then, yes, go for it, Carol.
The last question is just, what lessons have we learned from the first lockdown?
Well, we've learned a huge amount of lessons. And I don't know if you want to... it might be worth...
Can we make this a brief one, Secretary of State?
Well, how long is it? I mean, very long. So, for instance, I think probably the best example is schools. We've kept schools open in this second peak. We've done that based on a rigorous analysis that was done of the impact of schools being open on the transmission of the disease, on the impact of the disease on children, and then a judgment on top of that as well of the wider societal benefit of schools being open, and not least for education. So the scientific advice was that schools are lower risk than we thought. We didn't really know first time around. It was very hard to know. And added to the social benefits of education, and that's one of the things that we learned.
Thank you. Aaron Bell.
Thank you, Chair, and thank you, Secretary of State, for your time today. Following on from what Carol was saying about being guided by and following the science, clearly with these current national restrictions, the government did take a different view, because SAGE gave advice on the 21st of September and we didn't introduce national restrictions until the 31st of October. So what was the reason for doing that?
Well, the reason is that we wanted to pursue the regional tiered approach because of the lower wider implications of that. So again, the scientific advice takes into account the epidemiology, of course, but ministers rightly will also take into account other considerations. And at the time, the rate of both the prevalence and the rate of growth of the virus in many parts of the country was very, very low. And we judged that whilst we, of course, understood the science advice on the epidemiology, that it would have been disproportionate to have put in place a national lockdown at that time. And then, of course, over the forthcoming 6 weeks or so, things changed, and actually the trigger that persuaded me that we needed to go into national lockdown, having been essentially the architect of the tiered system and a big supporter of it, was that the trigger was that we saw case rates going up. And suddenly and quite sharply going up in almost every part of England, and therefore even in the low prevalence areas you could see that they were going to get to high prevalence if we didn't act. So that's a very good example of the difference between being guided by and following the science.
So in rejecting a call for a circuit breaker, a national circuit breaker, was that on the basis that you didn't think it would necessarily work, or that it wasn't necessary?
Well, I think that at that time a so-called circuit breaker would have been disproportionate. The challenge with a circuit breaker, the idea of a 2-week break, is what happens afterwards. And that's the debate that we're currently engaged in England right now, in terms of what happens following the Prime Minister's announcement yesterday of what happens after a lockdown. A lockdown is a lockdown is a lockdown. You can call it a circuit breaker if you like. A circuit breaker is just a 2-week lockdown. Here we went second time around for a 4-week lockdown, but critically, and then returning to a tiered system, which is better calibrated, having learned the impact of the tiered system in September and October, where the third tier wasn't strong enough to get the R below 1 and therefore cases falling, and therefore we need a slightly tougher third tier so that we can have confidence that we can bring cases down under the tiered system.
I'll let my colleague Mark Logan ask a bit more about easing restrictions, but do I understand that you don't believe a 2-week circuit breaker would have ultimately ended up being 2 weeks? You think it would probably have been longer?
Well, something would have had to come after it, because the sad truth is that until we get a vaccine that can effectively stop this thing, you've got to... NPIs are the tool that we have that is most effective. So the question is how to get to a point at which we can sustainably keep the virus under control. And let's go back to the strategy, right? The strategy is suppress the virus, protecting the economy, education and the NHS until a vaccine can make us safe. And we're going to use mass testing as much as we can to suppress the virus, but unfortunately, NPIs are also necessary. Whether you have a 2-week lockdown or a 4-week lockdown, that is simply a stronger set of NPIs to get the numbers under control, coming down, and then we'll replace it with a tiered system.
Thank you.
Thank you. Mark Logan.
Secretary of State, what way will Christmas look this year?
I don't yet know, Mark. It won't look exactly the same as normal, that's for sure, and it's very important that we continue to respect the spread of the virus, but I'm not leading on the discussions with the devolved authorities on what the exact measures will be.
And just from my constituents' point of view, at the end of July this year, a lot of my constituents felt like their Eid celebration was cancelled. A few weeks ago, quite a lot of my Hindu community felt like Diwali was cancelled for them. Are we considering just the perception of unfairness when we're looking to Christmas this year?
Yes, I'm very sensitive to this point, and we did think about it, and we engaged, and we have discussed it. The conclusion that we've come to, which I agree with, very strongly is that Christmas is a national holiday. It's the biggest national holiday that we have. Of course, it has particular importance for Christians, but it is an important national holiday for everybody in this country. Whilst of course we considered the impact on those of other faiths and none, Christmas is a special time for everyone in this country.
And just finally, I know we're very hopeful that by the springtime things will be back to relative normality, but between now and then, would you expect another national lockdown to happen?
No, I very much hope not to, by having a tiered system which is calibrated to be able to bring the virus under control where that's necessary.
Thank you.
Thank you very much. Taiwan.
Thank you, Chair. Thank you, Secretary of State. So I'm just going to go back and ask some questions with regards to the diagnostic capacity earlier in the year. On February the 4th, SAGE highlighted to the government the shortages around diagnostic capacity. Why is it that it took the government until April for the government to announce its new testing strategy?
Well, this is a really important question. In the period of the very early period, Public Health England did a brilliant job at developing a test at huge rapidity. And they began scaling up the testing capacity. And it was clear that we needed to go faster. And so in around mid-March, we broadened the responsibility for delivering testing capacity from just Public Health England. That became Pillar 1. And I took in hand into the department the responsibility for delivering testing capacity. And we built on top of the Pillar 1, which is the PHE NHS testing capacity. We also expanded we introduced Pillar 2, which became the Lighthouse Labs programme, and Pillars 3 and 4, Pillar 3 for antibody testing and Pillar 4 for survey and surveillance testing. And it was then that I was able to really drive the radical increase in capacity for testing that we can see today.
Thank you. Given that the government took their time in increasing the diagnostic capacity, what exactly has the government learned from this delay? Well,
what I'd say is that our challenge at the start was that we started with a very small diagnostics capacity. We started with diagnostics labs in the NHS and PHE, but they were really focused on the NHS labs on obviously the diagnostics for patients, and then the PHE capacity, essentially a scientific capacity. And what we didn't have was the large-scale community testing capacity. I think the main lesson I'd take away is that having built this global scale diagnostics capability, we now test more people than any other country in Europe. Having built this, we must hold on to it, and afterwards we must use it not just for coronavirus but everything. In fact, I want to have a change in the British way of doing things, where if in doubt get a test doesn't just refer to coronavirus but refers to any illness that you might have. Why in Britain do we think it's acceptable to soldier on and go into work if you have a flu symptoms or a runny nose, thus making your colleagues ill? I think that's something that is going to have to change. If you have in future, I hope, flu-like symptoms, you should get a test for it and find out what's wrong with you. And if you need to stay at home to protect others, then you should stay at home. We are peculiarly unusual and outliers in soldiering on and still going to work, and it kind of being the culture that you just, it doesn't. As long as you can get out of bed, you still should get into work. that should change. This year, there's been far, far fewer respiratory and other communicable diseases turning up in the NHS. I think that's partly because of the social distancing, because we're not, because the social distancing measures have an impact on the transmission of other diseases as well. So I want this massive diagnostics capacity to be core and to how we treat people in the NHS, so that we help people to stay healthy in the first place, rather than just looking after them when they're ill.
Thank you.
But given that we had universities, labs which were opened and local authorities wanted to help, did you not think that that was something that we should have learned from, and that we should have brought them in much earlier than was done?
Well, we did do that to a large degree. But there were some concerns we should have gone further, and I'll explain the answer to why we didn't do that. So what we did do was we brought in the capacity that that universities had, and in particular their lab machines. They were brilliant, the universities, in helping us to build the Lighthouse Lab in Milton Keynes, the first one. The challenge around testing, though, isn't just the machines and the lab itself. It's the whole logistics chain, from getting a test near to somebody, or indeed by post, through to getting the result sent to them and digitally into your patient record. The logistics around testing are huge, and are in fact far more complicated than the actual testing device itself once you've got the machine. The challenge with the university labs and other labs was one of scale, which is to scale up at the pace we needed to scale up. We needed essentially testing laboratory factories, and so we now are increasingly using the university capacity, but that's because we've got such capacity in the mass Lighthouse labs that we're able also to go and stitch in the smaller and scientific capacity into this. So it was about scale. It's a bit like in PPE when people complained to me that they could produce 10,000 gowns and we didn't give them a contract. Well, 10,000 gowns it's just a matter of scale. We were trying, and we absolutely succeeded in driving a massive expansion in scale, and for that we needed huge labs.
Thank you. Dawn Butler.
Thank you, Chair. Thank you, Secretary of State. Just picking up on that last bit that you mentioned, I think there was an issue with communication and systems that was used in the laboratory centres that you built, and the universities and established public health mechanism, which slowed down progress and communication and functionality. But I wanted to just talk about...
Yes, I'll absolutely acknowledge that. And I think that another lesson, another benefit that countries like South Korea had, was they had the IT systems in place to be able to do a lot of this, and building those IT systems at pace has been a huge and very difficult effort.
What proportion of contact tracing is carried out by local teams?
Well, I will try to find the figures for you. We publish them we publish figures on contact tracing every Thursday, but the broad picture is an increasing proportion, because we're getting the contacts to local teams as early as we can. But what I'm really pleased that we built the massive central capacity for contact tracing as well, because otherwise we simply couldn't have coped with the scale of contact tracing needed. And if you talk to my international counterparts about contact tracing, and we do, the ones who don't have a central system are absolutely tearing their hair out, because you need the massive central system and the boots on the ground who really know the local area. The key is the stitch up between the two.
Yeah, well, I think we found now that, which Long could have said in the beginning, that actually local tracing systems are much more effective than the national ones. But my constituency in Brent, for instance, have got a good programme that they're rolling out. How much additional resources have been provided to local authorities, for instance, to help with this rolling out of this?
Yes, so an additional £8 per resident per Council has been passed over to support this effort.
How does that compare to what was given to private companies for contact tracing?
Well, a lot of that is in turn spent on private companies to do local contact tracing. So that you've got if you want to get a public-private split, you have to look at a different set of figures, because then you're looking at who is employed directly by a public authority as opposed to who is brought in by contract. And so, I mean, I can get that split, but it's immaterial. What matters is the service that you're delivering.
I agree. It seems like the local service has been better than the national service.
Well, no. So it's the combination of the two that works. You see, one of the reasons that the local service can work a lot better is, of course, because there's boots on the ground. But it can't do that without the national system taking the big numbers. So what happens is that the national system is the first to get engaged, and they can cover off around 60% of the contacts.
They do the easy ones, don't they?
Not necessarily. It depends on the circumstances of individuals. So, for instance, the local system does care homes, and care homes are much, much easier to contact trace than almost any other setting. The local system does schools, and schools get, if one person in a bubble in a school get test positive, everybody else in that bubble is a contact, and obviously that means that if you just look at the raw percentages, then the numbers look like you've done an amazing job. But actually, so contact tracing a school, contact tracing a nursing home is easier than contact tracing individuals, and those are largely done by the local area. So that's why this unfortunate attempt, which some people try, which I'm sure you won't, to imply that public sector good, private sector bad, or local good, national bad, both of those things are completely counterproductive when we're trying to save lives.
Yeah, I think it's more public, you get much more value for money and is much more effective, reaching 80%, whereas the private sector costs a lot of money and averaged out about 48%. So I think it's that the comparison should be. But thank you very much.
Well, I've described why those figures are not the right way to make the comparison, and the idea it's just unfortunate. And I'll put on the record after this exchange my thanks to all those working in private sector contact tracing, because I really dislike it when people try to do them down.
Thank you, Rosie Cooper. Rosie, you need to unmute. I was going to have to say at some stage. You're still muted. The country is on edge, Rosie, as we wait for you to unmute.
Right,
there we
sorry,
are.
Yes.
I unmuted early, obviously too early, forgive me. Secretary of State, we're hearing about potential concessions being made if you test negative several times a week, and possibly a major reduction to isolation procedures if you test negative daily. Can you talk about the funding capability and the funding and the capability to deliver this across the UK in reality, not just being a wish list, but can we actually deliver it? And the other bit is, how can we establish the security and identity of the person being tested? How's that assured? Because we might get a situation where somebody gets test done by the wrong individual,
yes.
Not the named individual.
Yes. These are two great questions. I'm going to ask Jenny Harries to come in on this, because the scientific advice behind it is important as well. So on the capability to do this, the answer is we can only do this because of the enormous testing capability that we have built from, as we've heard earlier in the discussion, almost nothing at the start of the year, thanks to these unbelievable private sector companies that have done amazing science and who produce these testing capabilities. So we do have the test capacity. I was going to say, and then your second question asks it, The challenge is the logistical arrangements, identity assurance, and making sure that we get the tests to the right people. And this is currently being trialled from this week in Liverpool, and then we'll roll it out to NHS and social care staff. And from that, in January, should those pilots go well, we'll roll it out nationally. So we've got the test kits. That's in hand. The hard bit is the logistics. The point that you ask about identity insurance is very, very important because we'll want to know that people are doing the test. Now, the evidence, though, is that when people test positive, they are much, much more likely to isolate. So the isolation figures that the chair referred to earlier don't distinguish between people who actually have tested positive themselves. And the evidence that we have is that people who themselves have tested positive are much, much more likely to follow the self-isolation, not least because they may well be ill. And so all the points that you raise are part of the challenge in rolling out the programme. If I could bring in Jenny on the science.
Thank you, Secretary of State. Yes. So I was actually going to say that actually none of these are formally in use as a national measure at the moment, partly because they are undergoing very stringent evaluation, and the usability and feasibility of using tests in the field is part of understanding the scientific value of those tests. Having said that, they actually look very good. And for example, where they're being tested in different specific settings, so whether it be schools or workplaces, obviously there is a degree of oversight there in a potentially higher risk setting or a community focus that allows data to be collected, and all of the data from positive tests will be linked back to the national PHE data system. That is a critical point. All of the tests have to comply with the UK standard to ensure that the tests are only those which will deliver the right results. There are numerous lateral flow devices which have run through initial testing, I think over 130, but only a handful will come out the other end. But actually I think particular research has gone on with the London School of Hygiene and Tropical Medicine around the use, for example, in healthcare.
Forgive me interrupting. The question was about whether we've got the capacity to actually deliver that testing regime where we're telling people several times a week or maybe every day. And the follow-on to that was, if you tested negative twice in a week and you suddenly get symptoms, whether the lure of the football match you might be able to go to on Saturday might cause you to get somebody else to take that final test or somehow get around the system. So my question is, how do we distinguish between reality, what we can deliver on the ground, and what is essentially a wish list, and how much of this does it rely on the army and external forces?
So that's my...
Okay,
Sorry,
Jenny, you come in first, and then
to.
Secretary of State, and then I'm going to move on. Thank you.
I'll be very brief, because I think the important thing here is exactly those issues need to be worked out, which is exactly why the pilots are being run. But so far they have been very successful, and I think potentially good use in care home settings as well for testing healthcare workers there.
Secretary of State?
I was going to say exactly the same. This is why we're piloting them, to answer all the questions that Rosie asks.
Thank you very much. We're going to move on to the question of public messaging now, and Neil Hanvey has some questions.
Thank you, Chair. If I may, I'd just like to pick up a quick question, Secretary of State, on testing, but it relates to your appearance in several media appearances where you have stated that the lateral flow tests have a high degree of specificity and accuracy. Can you just explain or set out the reasons why you have that confidence?
Yes, in fact, Jenny Harries has just set it out, is that we put lateral flow tests and potential new technologies through a rigorous programme at Porton Down, And there have been over 100 new tests that have gone through that programme, but fewer than 6, I think, at the latest count, that have been approved. And we published the results, so that's why we can have that confidence.
On the reported variables on that success rate in the BMJ, where they highlight that the accuracy and specificity of the test, in other words, its success, it is based on the environment in which the test is conducted and by whom. And so they say that the high degree of accuracy results are conducted in a lab with specialist staff, whereas when it's conducted by healthcare staff or other staff out with that controlled environment, the success rate drops to 50%. And I'm just a bit concerned that in terms of giving the public confidence that this is a robust test, do you think you're overrating it a bit by saying that it's 99.6% when actually the real-world efficacy is around 58%?
The point that you raise is an important one, which is what matters is the sensitivity and specificity of tests when used in the field. The figures that you raise I don't recognise, not least because after having tested these the new generation tests important, we then put them through rigorous field testing. So for instance, we tested 5,000 of the first lateral flow devices alongside 5,000 PCR tests of the same people at the same time in the field. And that gave us confidence in the assessment of the test. So you're quite right that what matters is what happens in the field, not in the lab. I'm glad that the team went through the same assurance process as well.
Would you comment on another article in the BMJ from last week, where they characterised the current strategy as an unevaluated, under-designed and costly mess?
My assessment of that description is that it is wrong.
You don't have any concern about the in-field accuracy dropping to 50%?
That isn't the basis on which the results of all of this testing that we've done. This validation.
I appreciate that you're basing it on the 99.6%.
No, that wasn't my.
What I'm asking about is, do you think that gives an accurate representation of the programme to the general public when we can see that the actual results, which are published in the BMJ, these are not my figures, that the actual accuracy is somewhere around about 58%?
No, as I was saying, that's the reason that we've gone through this validation, is in order to have only use tests in which we have confidence and to use them for the right purpose. So the difference between an assessment of a test whose purpose is to find out if somebody is currently infectious rather than whether they have or have had the disease is important. So a test that is calibrated to find out if somebody is infectious can have an important purpose, especially if it's easier to use in the field. But you wouldn't use it for other purposes where you might want to know if somebody is not yet infectious but may potentially have the disease. So there are different tests that have different use cases. I don't know if Jenny wants to come in on this point as well.
I appreciate that. If I could just give another example. So out of 96,000 people without symptoms who were tested in Liverpool, there were only 842 of them that went on to have a positive test. And given that those people generally have a high viral load or are actively shedding it to some degree, I wonder what check has been done on a sample of the 96,000 people who didn't test positive to actually establish whether they were carrying the virus and were infected.
I'm going to bring in Jenny Harris on this point, and then I'm going to move on to Sarah Owen. Jenny Harris, do you want to just address that point? Thank you.
Yeah, thank you. And it may be helpful if we send in a note afterwards to explain this, because it's quite technical.
That will be helpful, thank you.
The point that I just want to make is, I think what the member was saying was around their use in different disease prevalences in different communities, and certainly that is a point of the feasibility of testing. These tests vary between 57% and around 75%, depending whether they are experienced users or not. So where they're being used in healthcare settings, that's absolutely fine. Where they are used systematically, say for example for a visitor who continues to visit regularly to a care home, that's likely to be very good as well. The specificity is around 99.5% as opposed to a gold standard of 99.95%. So all of these things are absolutely taken into account, and the comparator is they will work very well over the infectious period. Often a PCR test will pick up small amounts of viral disease. It doesn't mean that the individual is necessarily infectious. So I think all those things have been considered, and we're happy to send in a separate note afterwards to confirm.
That would be very helpful. Thank you very much. Thank you, Neil. Sarah Owen.
Thank you, Chair. Secretary of State, was Eat Out to Help Out a mistake, especially at a time when COVID-19 cases had already begun to rise?
Well, you always have to balance the needs of all the different considerations, the economy and the hospitality sector in particular, with the direct impact of NPIs. And that's what we do all of the time. Obviously, supporting the hospitality industry has been a very, very important part of trying to get through this. And in particular over the summer, when the number of cases was incredibly low, and many people could enjoy hospitality outdoors.
I mean, you talked about the economic impact, but in places like mine in Luton North, we actually got the lowest money from Eat Out to Help Out, only £25,000. You've claimed nearly double that in takeaways for your own team. So I'm just going to ask a couple more questions about Eat Out to Help Out and whether you believe that that was the right thing to do for the health of the nation. In making big policy decisions like Eat Out to Help Out and the restrictions in the tier structures that will soon follow, why don't you and will you consider publishing risk, impact and possibly transmission assessments for places like restaurants, pubs, gyms, schools and outdoor activities?
Well, Jenny can speak to the science around the transmission of individual places, but I just wanted to pick you up on one thing. I haven't claimed for anything, right?
No, I've asked you specifically whether you will publish risk assessments for places like restaurants, pubs, gyms, schools and outdoor activities.
Well, I was going to ask Jenny to come in on the already enormous amount of published information.
I'm sorry, publishing those assessments is within your power, not Jenny's.
I'm terribly sorry. I was answering a specific accusation in the first question, which I reject. You mentioned the amount of meals that we provided in the department and for the NHS, by the way, during the peak. And I will defend to the death the fact that when people are working 7 days a week, 18 hours a day, then it's perfectly reasonable that we should feed them. And that is, I think my team are amazing and have pulled an amazing shift this year, and they deserve to be fed whilst they're doing that work. And I joked on the radio that this is probably the best value for money food that you could ever buy, because it allowed the people who are working so hard to tackle this pandemic to keep working. And as for the accusation, which I don't know whether it was intended or not, that I personally had claimed for anything, is completely wrong. I have, like any minister, I've absolutely, well, not any, I mean, I have absolutely no personal interest in any of this other than saving lives for the nation. Having said all of that...
Okay, so in terms of saving lives for the nation, will you publish risk, impact and/or transmission assessments for things like restaurants, pubs, gyms, schools and outdoor activities, particularly when you have big policy decisions like Eat Out to Help Out?
So I was going to come on to that other part of your question and ask Jenny Harris to come in to describe the evidence that we have already published in this space. So the reason that I'm doing it that way is because we already publish a huge amount of evidence, as much as there can be. Now, the evidence isn't perfect because this is an imperfect science.
Why
Jenny
why didn't you publish the risk or impact assessment on Eat Out to Help Out before taking that decision?
Because we make decisions based on what we think is the best balance in a difficult circumstance where the evidence base is imperfect. And maybe Jenny can set out the evidence base that we have, which we extensively publish.
Thank you, Secretary of State. I think one of the points to answer in response to that question is actually the timing of our knowledge. So over the time period since the start of the pandemic, it's become increasingly clear, for example, that aerosol transmission and therefore ventilation is a really important part of managing risk with this infection. So I think whereas at the start of the pandemic we could make general statements to say, which we'd recognise in public health terms, that if you are in close prolonged proximity to individuals in an environment with poor ventilation, particularly in the winter, and you're there for social reasons, so the absolutely classic example would be a bar or a pub. What we do know now is going forward that we have more evidence accruing over the summer period, which now leads us to recognise particularly that increased likelihood of aerosol transmission is very much associated with things like singing and speech, which tend to be louder, for example, in social settings, aerobic activity, and places where you're not wearing face coverings, so obviously particularly where you're eating, where you're at the gym, where you're at parties, family gatherings. So there is a mechanical element to the risk associated with this, and then the sort of triangulation is to say, well, what happened in those areas, in those tiers where different interventions have been put in? And what we find looking back is in areas of where there have been hospitality interventions, if you like, we can see there has been some impact, and then there is direct epidemiological evidence, which again is difficult because you are looking at clusters of disease. People often won't remember precisely where they've been or how many people they've been with, so they will often translate that through to I was at home. That's the time you spend most of your time. But where that has been looked at in detail, there are large clusters right across the world, for example, in Japan, in Hong Kong, in Seoul, where we can see the association between hospitality and leisure venues and cases. And then the sort of gold standard is looking at genomics, where you're actually tracking a particular virus backwards. And where they've done that, for example, in the States, CDC Atlanta, you find broadly a risk ratio of about 2.8 to 3.8 in relation to hospitality settings.
Thank you.
Dr.
Does that
Harris.
answer your question, Sarah?
It does. The only other question that I had was, well, I might as well ask Dr. Harris, what role did she think the Eat Out to Help Out scheme has played in the imposition of the current national lockdown?
So I can't answer. As the Secretary of State has said, obviously it was a summer month period, and that's very different to now. From a public health perspective, now a hospitality setting going into winter where people are indoors and ventilation is much lower is a much riskier time period. And going back to some of the earlier comments, it's very difficult because, as we all recognise through this, there are behavioural elements, there are modelling elements, and there are mental health elements as well. So it's quite difficult to produce one quantitative assessment of that.
Thanks.
Thank you very much. Paul Bristow next.
Thank you, Chair. Secretary of State, the Treasury's Chief Economic Advisor has said that there are no specific estimate of the economic impacts of non-pharmaceutical interventions has been made. Is that correct?
It would be a matter for the Treasury, and I've got no reason to think that she's wrong.
Well, there's obviously a balance to be struck over restrictions, and that applies again regarding the treatment other than health conditions. Are you confident that the NPIs will be shown to be beneficial overall?
100% I am, yes. So if I answer the question a different way, of course we understand the economic impact of the NPIs. Of course we do. And in fact, in the cabinet papers that are prepared for the decision-making meetings, a description of the likely economic impact is made. The first question you asked was specifically about quantifying that. It is really, really hard to do that. But we, of course, understand the impact and feel it and take it into account. In a way, that's why we tried to run the tiering system for as long as possible until it became obvious that we needed to go to a national lockdown, because if rates are very low in one part of the country and not rising, then I wouldn't want to impose NPIs on that area that are not necessary. And that's one of the insights behind why I came up with the tiering system in the first place, was to try to protect some parts of the country from having NPIs that are necessary in other parts of the country but not there. Now, the new tiers are calibrated to be firmer, especially in tier 3 than the previous set, in order to make sure that we do have the tool there to be able to get cases down. So I suppose my answer to your question is yes, we know, we understand, and we feel the economic impacts. Of course we do, but the quantification is extremely hard.
Do you want to come in again, Paul?
Do you think deaths averted and perhaps... yes, if I could, Chair. Do you think deaths averted or quality of life years saved are the only really relevant factors here? I mean, do you not think perhaps unprecedented harm to freedoms and liberties and normal life should be part of those considerations?
Yes, I absolutely do. I think you've got to consider all these things. This comes back to the debate we were having at the start of the session about following the science versus being guided by the science. You know, because the medical science is only part of the equation to come out with the best judgment that you can. And I think sometimes, people overestimate the amount of information that there was, especially in the early days. Of course, the decisions in terms of impinging freedom weigh heavily on me and certainly on the Prime Minister. The economic impacts are obvious. I came into politics to try to improve economic chances for people. That was my background that led me here, and now I find myself doing this. But the reason that I can say 100% I think that the NPIs have been necessary is that we also know that if the cases go up, if R is above 1, then ultimately that is exponential, and that means that they will go up more and more sharply. The inevitable consequence of that is that we will bring in stronger NPIs to bring it down, and that has a bigger economic consequence. And I think therefore, the lesson of hit it hard and hit it early is an important one.
Okay, just one last question, if I may. I've personally seen quite a lot of anecdotal evidence and even experienced some anecdotal evidence that COVID has been recorded as a factor on a precautionary basis and often without proper evidence on death certificates. Are you confident that death certificates have always been, throughout this pandemic, an accurate basis in assessing prevalence of COVID?
I think it's a serious challenge. I think the question you raise is an entirely reasonable one. You'll have seen over the summer the difficulties that we got into over the publication of the deaths measure, because the original PHE measure included anybody who had tested positive for coronavirus, which was perfectly valid at the start, but by the summer you had people dying of other things having previously had and recovered from coronavirus. The measures on death certificates are what they are. The Chief Medical Officer, if he was sat here, always says that the only true measure is the measure of excess deaths, because that's the one measure that is internationally comparable that you can't avoid.
Okay, thank you.
Thank you. Dean Russell.
Thank you, Chair. Thank you, Secretary of State. Across my constituency, I've been chatting to quite a few head teachers, and they've been concerned about the fact that they weren't on the priority list of the first 11 around vaccinations. And I think from an economic perspective, schools have helped parents go to work. They've been able to help make sure grandparents weren't looking after young children. I just wanted to get a sense of, why they weren't on that priority list, but also what other support is in place for our incredible teaching workforce.
So I'll give a short answer to this and then ask Clara Swinson to come in, because the prioritisation of vaccines is obviously incredibly important. We take the advice from the Joint Committee on Vaccinations and Immunisations, and our judgment is that you need to go in order of clinical priority for two reasons. Firstly, directly to reduce as soon as possible the number of people dying from COVID. But the second is that this is the best way to recover economically as well, because as you can stop people going to hospital and dying from COVID, that's the quickest way to lifting NPIs, which is the thing that will get the economy going. In terms of teachers, they are, on the evidence I've seen, they are not any more at risk than the wider population for catching COVID. But I also understand the pressures on teachers, in particular having to isolate if they're a contact. And I hope that if we manage to get the repeat testing instead of isolation for contacts working, I think that will be a huge benefit to schools. And I really hope that we can get there in the new year. Clara.
Thanks. So just to add to that, the provisional prioritisation that the have done is both on age and also for health and care workers. Any teacher, like any other adult who is at high risk, under 65 would also be covered in the 1 to 10, but as Secretary of State said, on the basis of the rest of the population. Of course, JCVI will assess each individual vaccine as it comes on, and all being well, if the vaccines come through, the government has procured enough both for those in the first provisional prioritisation, but then we will need to move on to prioritisation and for those under 65 for the rest of the adult population.
Thank you. And may I ask, taking that slightly further, I mentioned about the fact that schools have enabled parents to go to work. One of the things that's actually caused a huge amount of days lost in the workplace this year has been through mental health and the impact of mental health. There was one piece of facts that I saw earlier this year, which I wrote about, which were over 32 million days worth of unpaid leave were taken in the UK, equating to £4.2 billion in losses, primarily due to sickness leave related to mental health. That is a risk that's going to go forward into the next few years. I just want to understand how mental health is being prioritised by the government and by the department to support all those that are affected by the pandemic this year.
Well, yes, it's incredibly important. In fact, the Mental Health Minister has set out more details in the last few hours of extra support that we're putting in to support people. There are undoubtedly mental health impacts of lockdown. There are also, very sadly, some quite serious mental health impacts of coronavirus itself, because it can be a neurological condition in some, and therefore this is it's a very serious challenge, and we're putting in extra funding to support colleagues in the mental health field.
Thank you. And then very finally, just one of the things that's come out over the past few months very severely is the impact of long COVID. I'm just wondering what level of research is being undertaken at the moment around what the impacts might be very long term around long COVID. I appreciate it's not been something that's been around for long enough to know all the details, but what measures are being put into place both on the research side but also the treatment side? Yes, long COVID is really serious for some people, and it's a problem that we've got to support the NHS to address. We're doing that both through funding from the National Institute of Health Research, and also the NHS itself has now opened a long COVID service. I think there are 8 centres already open, and we'll have 40 open by the end of the year, covering all parts of England. And I know the NHS in Scotland, Wales and Northern Ireland is also working on this. It's very difficult. The science, as you say, is very early. Also, there's a very wide array of symptoms, so it's quite hard to get to the bottom of. But it's very, very serious for those who are impacted. And my heart goes out to them. It's an incredibly frustrating position to be in, especially if you're now 9-10 months on from having had COVID and you're not getting better, and typically basically exhausted most of the time, often with associated pain or neurological conditions. It can be really debilitating.
And we've had a lot of correspondence on that, and thank you for the support of your officials in trying to get to the bottom of some of those issues. Greg Clark.
Thank you, and thank you, Secretary of State, for appearing before us today. In its minutes on the 21st of September, in considering the lockdown measures, Sage said, and I quote, that policymakers will need to consider analysis of economic impacts and the associated harms alongside this epidemiological assessment, and that the work is currently underway under the auspices of the chief economist.
Yes.
Are you one of those policymakers? Are you
Yes.
part of the decision as to how lockdown measures are imposed?
Yes, of course. I mean, this is a precise formulation of being guided by the
absolutely. And you've said that there's SAGE advice and there's other advice. Yeah. You referred to engineering advice. So, given that you're part of the policy making team that makes the decisions, have you seen the economic advice?
I have seen economic advice, which is prepared ahead of those meetings. The previous discussion we had on this was based on, I think, it being incredibly hard to have a numerical estimate of the impact of any measure, not least.
But there is advice. There is written advice and papers.
Written advice in the cabinet papers.
So why can't we see it? We see SAGE papers. They are published. Our committees have called for and resulted in the publication of all of the papers that SAGE considers, and indeed the minutes of their meetings. Given it's been very clear that there is a stream of, as it were, pure scientific advice and very important other assessments, why should they not be published?
Well, cabinet papers are not typically published to protect decision making, but I'd also
why should they be more protected than the SAGE papers?
I'd also make a distinction. The SAGE papers are the papers that are the result of a discussion of the scientific community on SAGE, which then come to the Chief Medical Officer and CSA. The CMO and CSA then put their advice in cabinet papers to us as the decision makers in cabinet or typically cabinet committees. Those papers are not published, quite rightly, because ministers need to have the space to make decisions. However, having said that, on the economic front, also, whilst it is harder to put the figures on the economic impact, you also need to consider the counterfactual. So the counterfactual in economic impact is even harder to work out than the direct impact of the measures.
All the more reason to see the assessments that have been made. The counterfactuals are important in scientific advice as well.
No, yes, but on the economic side, the problem is that if the virus gets out of control, then you need to bring in other NPRs.
Why is it a secret, Secretary of State? We've got important debates in this House. SAGE themselves have said that it's important to consider the economic impacts and others. The scientists publish their advice. why shouldn't you publish the other crucial advice that pertains to these very important decisions that are affecting the whole country and all of our constituents?
Well, I think it's reasonable for cabinet committees to be able to be served papers by the civil service, guided by the science, on which they make decisions that are then that are not fettered by the thought that they may soon be published. That's a long-standing convention of how you run government, that there has to be a protected space for decision making.
Prime Minister made a statement yesterday about a new set of tiered restrictions. Have you considered the economic and other impacts of the different tiers that are proposed?
Of course, we've considered that. Yes.
Have you?
Yes, of
so
course.
You've been part of that.
I consider that as part of coming to a view about what we need to do. And the way that I think about it is this, that it is critical that we have a tier in a tiered system for it to work that has R below.
No one's doubting
I was going to come to the economic point.
Can Parliament not be taken into to your confidence in the way that it is with scientific advice that's given to you?
Well, the advice that goes to the advice that forms the basis of those cabinet papers, I see the cabinet papers with the economic assessment, and I think it's reasonable that they should be written without the expectation of imminent publication.
Do you challenge that advice and question that advice?
Yes, and what I was coming on to trying to say, and I apologise, a slightly too long-winded way, my previous answer, was that what we're trying to pull off here is what is the set of measures that will get R below 1 that has the minimum damaging economic impact. Because otherwise, if you don't manage to get R below 1, then you have an even more damaging economic impact.
No one doubts at all the intention, but we want to be reassured that policy is being taken on a rigorous basis. In terms of challenging and questioning the advice, on 31st of October, on Halloween, Sir Patrick Vallance presented a slide that included a scenario in which there would be a peak of 4,000 daily deaths. Had you seen that slide before it was presented?
I had seen it, and I understood it to be what it was, which was one of 4 different projections.
But it was out of date, wasn't it?
Well, it was clear, and it said so on the chart, and that I took that into account along with everything else.
Did you question whether it should be presented to the public on that date?
I thought it was a reasonable judgment for the CSA, not for me.
Even though there was other more recent advice, part of your challenge wasn't to suggest that actually the more recent data should be used.
No, I thought that presenting a series of options was important because it made it clear and absolutely crystal clear to anybody listening to that presentation that these things are not certain. Right? We're not dealing in a world of knowing exactly what the consequences of each decision will be. You've got to deal in a world of uncertainty. That's one of the biggest challenges of the whole pandemic.
It's been useful to see that advice, and there's been some scrutiny of it, but we don't have the chance to do that with the economic advice and the other assessments. Would you consider making that available to Parliament?
I will talk to the Chancellor about it.
Thank you. Barbara Keeley.
Thank you, Chair. Secretary of State, I've got a few questions on visits to care homes and also on COVID and people with learning disabilities. First on visits, why has it taken more than a month to begin the pilot of regular testing for care home visiting when vulnerable people with dementia have been denied visitors for so long already? And when will we see the rollout of visits to other areas of the country?
Yes, well, we have those pilots running now, and it hasn't taken. There hasn't been a delay in this. It's been about getting it out as quickly as can safely happen. And the debate about visiting in care homes it has to take into account both sides of this equation. Sometimes I think that the public debate is only about the restrictions against visiting. There's also the vital importance of protecting people who live in care homes from COVID, which we all understand. And in the second peak, in fact, the proportion of people in care homes, the proportion of people who've died who live in care homes is lower than first time around. These are some of the lessons that we learned. So we have to act carefully and cautiously. I hope that the rollout will be able to be available to all care homes by Christmas, and that is the goal that we're working to.
Okay, thank you. On COVID and people with learning disabilities, Public Health England has recently published data suggesting people with learning disabilities are 6 times more likely to have died from COVID-19 than the general population. Yet the response we've seen so far from ministers is that there's going to be a review of that report. What action can we expect on that level of disparity in deaths from COVID among those people with learning disabilities?
Well, ensuring that we protect people with learning disabilities is obviously absolutely critical, and we look into it in terms of in the same way that we look into all of those who are more affected by COVID. I'll ask Jenny to come in a second, but the critical part of that analysis before we get to the policy, which I'll come on to, is to make sure you also take into account comorbidities, because we know that after age and sex, that obesity is one of the other major factors, and there are other comorbidities that we have to take into account. However, even taking all those comorbidities into account, there is a higher prevalence of mortality from COVID for people with learning disabilities, and of course we consider that when we are looking at the clinically extremely vulnerable group and the support that we give them, and it's through.
But they're not. If I could say people with learning disabilities are not clinically extremely vulnerable. I mean, one of the points you might want to take into account is that care staff working with people with learning disabilities didn't get access to regular testing till at least September. I mean, this report from Public Health in England has been out for some time, and I really feel there hasn't been any attention to the needs of people with learning disabilities, but certainly testing wasn't rolled out.
Well, it was as we were building the capacity of testing, we discussed the capacity of testing earlier in the session. One of the, people talk in the abstract about this capacity for testing. One of the reasons it matters is to be able to do, as we did in September, exactly what you say, and also be able to roll out testing to enable visiting in care homes. It really matters, this testing capacity.
It's not just care homes, though. A lot of people with learning disabilities also live in a supported basis on the community, and they haven't been community tested.
Of course.
These weren't prioritised, were they?
Of course, they are. What matters is the clinical risk. I just want to pick up a couple of things. You asked me a question about care homes, which is why I answered about care homes. And when it comes to the clinically extremely vulnerable, of course there isn't a blanket. All those with learning disabilities are clinically extremely vulnerable, but there are groups where that vulnerability can be assessed. I think it's worth bringing Jenny Harries in, because this is her area of specialism, and she's done an incredible amount of work in trying to get the best possible to support.
Okay, as long as I could clarify, my first question was on care homes. This question is about people with a learning disability, and they don't all live in care homes. Some of them do. Quite a lot of them live in mental health units.
Shall I pick that point up? So I'm very familiar with the PhD report. I've reviewed it myself, and also there was another report recently, the Lader report published by NHSE, which was more a qualitative assessment of deaths in those with learning disabilities, but nevertheless was an important source. And in fact, the Minister of Care has asked the SAGE subgroup, which I chair on care, since July, to look at both of those reports, which we did, I think it was last Friday, it's very recently, because of the potential importance of the information. The point, there's one very basic point that we all need to learn going forward, which is the data is extremely unreliable. Now, that's not to get away from the founding of the report, but it's to say that a key point going forward for learning disabled populations is to ensure that primary care data is really, really strong on learning disability, and particularly on ethnicity as well. And the reason I mention that is because it makes it very difficult to understand the true risk which is inherent in some of the data that's presented. PHE report is very much extrapolated data because that's the only way they can handle it. So really important points for learning disability going forward is around the data. For some of those learning disabled, they do fall actually within the clinically extremely vulnerable group because they will have other conditions with learning disability, not all, so they will get picked up with clinically extremely vulnerable. But one of the key issues about both of those reports is that it doesn't distinguish between well enough between those with Down syndrome and those with other learning disabilities. Now, Down syndrome is one where we have already acted and ensured that where we've seen this risk of increased risk, those individuals now have been moved over, are currently being moved over, adults, into the clinically extremely vulnerable group. So I hope that's reassuring that those are actively been looked at and acted upon, and definitely we need better data going forward, and we'll keep monitoring them.
Thank you very much, Barbara. Final one.
I've got one final question, yes. Back to visiting, because it isn't just about older people. Many families of people with learning disabilities in those care homes or mental health units are not able to visit. There's a lot of blanket bans on visiting for those families, of those younger people. At a meeting with families last week, I was told by a mother that her son's social worker had to ask the care staff in her home to bring her son to the window so that she could check he was still alive. What I want to ask in terms of visits is, who can check on the care being delivered in those places when there is a blanket ban on visits? Because there was real concern among the families I talked to that they were not being allowed to visit and check on the care that's being delivered. We know, Secretary of State, and I think you know too, that there's very high levels of inadequate care for that group of people.
Well, the formal responsibility of the system, of course, falls to the CQC. Who do have that responsibility? Who haven't been inspecting during the pandemic? They haven't been inspecting. They do have access to. They are able to inspect. But I appreciate that. The reason I said that is the formal responsibility, because of course a huge amount of the checking and looking after people in these settings is of course family and loved ones, and I hope that we'll be able to get them visiting soon.
Thank you.
Final thing, could I just say, would you make that a priority? Because I think that's an important commitment.
Yes.
Thank you. I just want to follow up on that issue of potential discrimination against people with learning disabilities. The vaccine guidance issued by JCVI says that all older people, including a healthy 65-year-old, has to get the vaccine before anyone with learning disabilities under the age of 65 will get it. Could you just look into that? I know that vaccine guidance is continually under review, but could you just look into that and let us know whether, on the basis of some of the questions that you've heard, that is something you would reconsider? Because for people with learning disabilities who have this much higher chance of fatality from COVID, that feels discriminatory.
Yes, and in fact, I've already asked Professor Van Tam, who is our clinical link to the JCVI, to consider exactly this question. JCVI are rightly an independent clinical group, but it's totally reasonable for my clinical advisors to ask them questions, and I've set that in train.
Thank you very much. Laura Trott.
Thank you, Chair. Secretary of State, when you were last in front of the committee, I asked you about parental access to neonatal units. Bliss, which is a charity which supports premature and sick babies, is still reporting limited access for parents. What's being done to address this?
Yes, I think this is incredibly important, and we changed the national guidance to the NHS to allow for and encourage visiting, and I think that guidance should be followed.
And in cases where units are not allowing parents unfettered access, what is the process for fixing that?
Well, the process for fixing that is that it's a responsibility for NHS England and NHS Improvement as essentially the regulator of hospitals. I think we need to have a continued drive to open this up and use testing to give people additional assurance that having a partner with you can be done in a safe way.
And so to follow up on that, is a testing regime being considered for parental access to neonatal units and also paediatric wards?
Yes, it's being considered, but we're not there yet. But I hope that we can get the clinical protocols signed off.
And what will be required to do that? Is there any reason why it's being held up versus, for example, visits to care homes?
Well, in the same way that visits to care homes are being piloted, we'll need to make sure that the clinical protocols are signed off to make sure that it's safe, and then the logistics of the rollout, which in this case should be relatively straightforward because they're hospital settings.
Thank you. Do you have a time frame on that?
I can't give you a time frame today, but I'll write to the committee when we've managed to establish one.
Thank you.
If that's okay.
Chair.
Thank you very much. Aaron Bell has a follow-up question.
Thank you, Chair. Secretary of State, following up from actually the very first question that Jeremy Hunt asked at the start of the session about the impact of a vaccine on the future of NPIs, you obviously said in general terms we'd hope to release them. I mean, the reason that most people have been prepared to follow the NPIs at the sacrifice, most healthy people, is because they understand their responsibility to the most vulnerable in society. But my question is, how far down the priority list do we have to go before we can start to take off those MPIs for everybody else? Because if we get down to 0.7, say, moderate risk of adults under 65 years of age, once we've vaccinated them, doesn't the case for the MPIs dissolve? We're not at that point, people could take their own risks about seeing people, about socialising, all those sorts of things.
Well, that is absolutely the goal, and there's a couple of things that make it challenging in practice. The first is, of course, when you say vaccinate, that has to mean both doses and then a short period after the second dose. So that means that this isn't immediate. One of the current vaccines that's with the Pfizer vaccine requires 2 jabs 21 days apart. The AstraZeneca 2 jabs 28 days apart. So there's a bit of time there that we need to go through. And we will need to obviously have the vaccination programme deliver to all those people. But I also think that should we manage to get the number of deaths, the number of hospitalisations down sharply because of the vaccination programme, i.e. if the vaccination programme works, and we should have confidence that it will because it has in the clinical trials, it's the safety data and that data that needs to be checked by the MHRA. But should all of that come to pass, then essentially I think we'll get to the point where we are protecting the most vulnerable, and there the argument for more personal responsibility in how we respond to this, rather than NPIs, particularly the NPIs that damage the economy or damage societal well-being. I think that is where we'll get to, yes.
So does that mean we'll be able to tolerate higher overall case rates if we are then confident that the case rate amongst the most vulnerable is effectively zero or close to zero because of the vaccination programme?
Well, it's this thinking that underpins us saying that we think that we will start getting back to normal after Easter. Of course, a case rate in lower morbidity and mortality groups is obviously less damaging to everybody. The risk and the problem, for instance, with the big student outbreaks that we had in September was that it gets into the wider community, and that's exactly what happened in places like Nottingham and others. But once you have protected or given the opportunity to protect older people and more vulnerable people, then obviously the public health rationale, particularly for strict and damaging measures, is reduced in exactly the balance that we were talking about earlier in the session. I'd say something else though, which is an important consideration in this, which is that, of course, there is long COVID too, which affects people irrespective of age. And we may get to a point, if the vaccines reduce transmission of the virus, then we may get to a point where we get where the vaccine means that enough people are vaccinated that the virus stops transmitting, because it on its own, or with non-damaging NPIs, if you like, washing your hands, etc., brings R below 1, and then the virus won't be able to take hold, and then you won't even get the long COVID consequences, because you won't get the case rates. So, so even on the grounds of just protecting those who are most at risk, there's a case for the argument that you put in terms of then removing some of the most damaging NPIs. But there's an even better option that we don't know if it will come to pass, but it might, which is that on its own, with basic hygiene, the no regrets NPIs, the vaccine gets R below 1. If that comes to pass, and I'm not projecting that or predicting it, but I'm explaining that is one potential outcome, then obviously that's brilliant for everyone.
Thank you.
Just a brief one, Aaron.
Yeah, sorry, I just wanted to get a final answer on the first question I asked. Is there a particular category of people you want to get to on that priority list before you consider that we have protected the most vulnerable? Is it down to 0.7, moderate risk adults under 65?
The JCVI's advice is that we should go down to 0.10.
Right, thank you.
Thank you. Luke Evans.
Thank you, Secretary of State. And I'm interested, as this is lessons learned in looking at the positive legacy and the future, given everything we've been through in the pandemic. If you could cast on that legacy side, when you came before us, you talked about the role of telemedicine and the referrals to A&E particularly. That might be something that's staying in the future. Could you update us on whether that is likely to be the case?
Well, yes. So I think this is a really, really important part of the work that we're doing. Of course, learning the lessons from what didn't go well is important, but learning the lessons from what did is sometimes easy to forget in the circumstances, but also absolutely critical. I'd mention a few things. So on telemedicine, I absolutely think that we should keep the benefits that we've gained. The proportion of telemedicine dropped back by a couple of percentage points, which kind of tells me that we've settled at about the right level in terms of around 45% of primary care appointments now, for instance, are by telemedicine. Before everybody knew it should be higher. Now the question is, what is the right level? And that feels about right to me. We've also made big advances in the NHS on reducing bureaucracy. In fact, I'm publishing a paper today on busting bureaucracy in the NHS. Taking forward measures that we've learned through the crisis are important for helping people to get on and do their job in a safe way, but without some of the layers of bureaucracy which had built up, and taking forward some of the proposals which had been developed before but not yet put in place by the NHS. So they're two things, but I think there's a whole range of things that we've learned that have gone well.
A dedicated team is, thanks, Secretary. Is there a dedicated team looking at that? And going forward, I mean, you've got millions of people signed up to an app that hopefully we won't need to be using in the summer. We've got a testing capacity, which you did hint about with the super labs coming on, and also an army of volunteers who all signed up to support the NHS. And I believe there's a 10-minute rule bill today about using that and keeping some NHS reserves. Are these plans in place? Have you got a dedicated team looking at all the positive things that we can take forward that will make the NHS better?
Yes, I'll bring Clara in a second, but my strategy team in the department look at all of these things, and of course I work with the NHS on it. The app, I can tell you, now has over 20 million downloads, which is unique downloads, which is absolutely superb. We've also we've built the diagnostic capacity, and it's critical that we keep that, and we have a long-term diagnostics industry.
With that app, if I could just interrupt, with that app, are you planning a use for that now we've got 20 million people signed up?
Well, I hope that we can get more people. I was going to come on to this, because as well as telemedicine, which is in a way the most obvious use of digital technology in medicine, actually I want to ensure that we accelerate, and we use the crisis to accelerate the engagement of all, or at least the vast majority of citizens, with their healthcare through modern technology. So you wouldn't do this directly through the app, the COVID app, because it's anonymous, but people are far more engaged with their health, and we can use some of the technology that we've had to build, that we were talking about before, to help to ensure that patients are more engaged with their healthcare and can easily access the data around their healthcare, and that we have better, appropriate data sharing within the health system, which can save lives.
And finally, I asked you in the House before, after we heard evidence in this committee, about the potential of doing the equivalent of virus drills in care homes. That was evidence we heard from what happens in Hong Kong. Is this something that the NHS will consider taking forward to implement, like you'd have a fire drill, we'd have a virus drill, particularly in care homes and the vulnerable settings?
Well, in care homes that wouldn't be for the NHS, but nevertheless, it's a terrific idea, and I think I'll give it to my team who take forward ideas like this to see if we should put that into place afterwards.
Thank you very much, Chair.
Thank you very much. Graham Stringer.
Secretary of State, why have you decided, when you're imposing different tiers on regions, not to negotiate with locally elected representatives?
The reason that we're doing it differently is because whilst in most cases when we negotiated with most areas in the previous tiered arrangement, we had a high quality discussion that led to better outcomes. A case in point is Liverpool, where the case rate has fallen by over 2/3 in the last 3 weeks. In fact, Joe Anderson has texted me during this hearing, and he has done a magnificent job. And the teamwork between the national team and the local team was very high quality. Unfortunately, that wasn't the case in all local areas. And sadly,
are you talking about Greater Manchester?
Well, that would be one example, but not the only one. But sadly, in the case of Greater Manchester, cases carried on going up whilst we were trying to put in place the measures that were necessary. So instead, we've proposed the set of tiers which are fixed. A set of measures within the tiers which are fixed, also financial support which is agreed by formula rather than by negotiation. We will of course engage with local authorities, and some of that engagement is going on today ahead of the Gold meeting and the decisions that will be announced on Thursday. And we'll engage with colleagues as well. I had a Zoom last night that all cross-party MPs were invited to. So we will have that engagement, but what we won't have is a 2-week-long negotiation whilst the cases still go up that is bad for public health.
Will you be publishing the exact and precise criteria which will determine which region goes into which tier?
So I addressed this in the House yesterday when I was standing in for the PM. We've set out the 5 indicators that we will look at, but we can't credibly put a set of statistics on those, because when you're looking at 5 different measures, you've got to take into account the basket. And also because there can be circumstances where there's an individual case. I mentioned yesterday a case on a barracks, which was where the problem was literally confined on the barracks, and it would have been unreasonable to have followed an automatic process based on fixed thresholds, and that's why we've come to the decision that we have.
Will you publish a cost-benefit analysis for each region?
We publish all of the data that underpins the decision that we make. So my goal here is to ensure that we publish the data on which the decision is made, we publish the decision and an explanation for that decision, so that people can understand why we've had to take the decisions we've had to take.
But that doesn't include a cost-benefit analysis.
Well, by its nature, it will include the considerations that we've taken into account. Yes.
So, not a full cost-benefit analysis. The point I'm coming to, and I understand the difficulties that there are where you've got a very, as you say, a very tight, infected group of people, and transposing that into hard criteria. You're going to end up making political decisions. You're not going to negotiate with elected politicians. So how would I, as an outside observer, be able to tell that you're not just practicing arbitrary government?
Because we're going to publish the data on which the decisions are made and explain those decisions. And these decisions are not political, but they are ministerial in that they take into account all necessary considerations.
Thank you.
Greg Clark.
And just specifically on this, will these decisions be scientifically informed, particularly to reflect real patterns of community and movement, not arbitrary administrative boundaries? In the case of Kent, for example, the movement in West Kent, the movement is up and down to London and across to East Sussex.
Yes.
Very different from North Kent coastally. Will that be reflected rigorously in the decisions that you make?
Yes.
Thank you.
Thank you. And last but not least, Dawn Butler.
Thank you very much, Chair. Secretary of State, during this lessons learned evidence session, it's important, as you said, that we know what went right so we can do more of it, and we know what's gone wrong so we can stop it and never do it again. Byline News published the official government records of meetings, and one of your ministers at the Department of Health met with Topham Gurin to discuss test, trace and marketing. So I'm a bit confused why you refused to answer this question at the evidence session on the 21st of July. I think it's either you don't know what's going on in your department, or you didn't further send clarification, as the chair had suggested you could do, or you deliberately misled the committee. Which one is it?
I'm sorry, I haven't deliberately misled the committee. I don't really understand the previous...
So on the 21st of July, I asked you the involvement of Topham Gurin with the test and trace with the Department of Health, and you said it's got nothing to do with the department. But on looking at the ministerial records, one of your ministers have actually met with Topham Gurin to discuss test, trace and marketing. So it has got something to do with your department.
Right. We meet an awful lot of people, and we meet people who can help us to tackle this virus. And as far as I understand it, Topham Gurin are an organisation which can help understand public sentiment, public views, and obviously the public's views are a material factor in how successful a public health intervention can be. It's not just about taking these decisions that we've been talking about and implementing them as we've been talking about. It's about how the public responds.
So do you know the involvement of Topham Gurin and what they've done for your department?
No.
Okay. So, I mean, they were given £1.5 million to do marketing for your department. And they must have done a good job, because that contract's now been extended and they've been given another £1.5 million. They were given £3 million in total. I think it is really important that we understand the role that Topham Gurin has played in the department, and that you inform the committee what they've done and how they've done it, so that we know whether we've received value for money. Because your Minister Lord Bethell said that lots of contracts have been given by informal arrangements. And I wonder whether Topham Gurin were given this contract because they worked on the Conservative 2019 election campaign.
As I say, Topham Gurin is an excellent organisation, and we use all sorts of excellent organisations in the Department for Health, and understanding the public's response to the actions that were taken are absolutely critical. Yeah. So I don't think there's any issue here at all.
I mean, it is interesting that you say that they're an excellent...
Also, there's a point about formality. All contracts in the department are properly signed off, and that's done by the brilliant civil service team, taking into account the the conditions at the time. So
Secretary of State, I think the National Audit Office recent report would says something very differently.
No, on the contrary,
and
it's worth.
Fact,
if I can just respond to that point, the National Audit Office report demonstrated that within the department there are sign-off steps that make sure that even though we had to move incredibly fast in order to save lives, all contracts were signed off properly and appropriately within the civil service, within the rules. And in fact, the fact that the National Audit Office is then able to come and audit all of these contracts demonstrates the transparency of the system within which we operate.
Secretary of State, the National Audit Office says that all the paperwork is not present that they need to enable to follow the trail of contracts that have been issued. But there's 2 points I just want to quickly make. You said that Topham Gurum is a great organisation. Well, they have been found during the general election 2019 that 88% of their most shared adverts online between the 1st and the 4th of December contained misleading information. I'm not quite sure that qualifies them as a good organisation, but just going back to the National Audit Office, National Audit Office said that a company was put in the high priority lane by mistake. How is that possible, Secretary of State?
Well, the National Audit Office report, contrary to what you've just said, explained that it was able to look at all of the contracts that were signed. I think it's a strength of the British system that the National Audit Office can do that. Of course, there was a massive amount of work to get PPE to keep people safe. I'm absolutely delighted that the National Audit Office found no evidence.
Secretary of State, how can a company be put in a high priority lane by mistake?
Because all requests went through all of the appropriate stages of the procurement.
Secretary of State, this company then went on to get a £350 million contract.
Well, many businesses went on to get to deliver services for the NHS,
but it's by mistake, and they didn't deliver.
No, I'm terribly sorry to disappoint you in this, but all requests went through the proper procurement process. Of course, that procurement process was the emergency process rather than the normal one, because we were in an emergency. We took, in terms of that particular route that you talk about, we absolutely prioritised credible offers to make sure that they could be. I'm finished. If I just finish the answer to the question, we prioritised credible offers where we found them. We prioritised credible offers where we found them. We took in credible offers from all comers. In fact, we did a public call to arms. We had support and proposals put forward that went into, that were looked at from members of the Labour Party, members of the Liberal Democrats. The BMA were brilliant, we worked with them. The RCN, that we worked with them. We worked with anybody to make sure that we could get as much, in this case PPE, as possible in those contracting arrangements, and that is all borne out by the National Audit Office report.
Nobody's denying it's a difficult job. Nobody's denying it was a mammoth feat to where we've gotten to, but if we're going to learn the lessons, we really have to be honest about what's happened.
That's right,
Thank you very much.
And the National Audit Office, I'm delighted to say, is able to come and audit all these things.
Thank you, Secretary of State. You've been very generous. A very final, and I've been promised it is just one question from Rosie Cooper.
Thank you, Secretary of State. It's reported that 4 Treasury civil servants are leading the Health and Social Care Task Force. Could I ask you what involvement and input you've had with this task force, and whether the government will publish its terms of reference, minutes of its meetings, to allay fears that there are secret plans to reorganise the NHS?
There are the policy over the NHS is set by the department, and obviously in close consultation with the Prime Minister, Number 10, and where relevant, other government departments.
Thank you. Okay. Rosie, we did say one question, so there's lots to be unpacked there in future sessions. Secretary of State, you've been very generous with your time this morning. There's a lot on. We're very, very grateful to you. We're very grateful to Clara Swinson and Dr. Jenny Harris also for joining us this morning. Thank you very much indeed. Order all.
Thank you.
Thank you.
Social Care and Science and Tech Committee Tuesday the 24th of November 2020, the Wilson Room. Health and Social Care and Science and Tech Committee, Tuesday the 24th of November 2020, the Wilson Room.